Uh,
Shall we start then, Dr. Samri?
yeah. Good evening to all of you, and welcome to Sri Lanka Veterinary Association webinar series. And today our webinar is little different from the webinars which we had earlier. Normally, we conduct webinars to educate our veterinarians related to diseases related to animals or scientific writing methods. But today it's different. Today webinar is about human health, especially the cardiac diseases and the diabetes. As you all know, yesterday is the World Veterinary Day, and the theme of the World Veterinary Day yesterday theme is strengthening the veterinary resilience. So under that theme, they have identified that veterinarians, much like the animals they take care of, need proper tools and support to maintain their health and wellness. So by considering that one also, and also according to our constitution, Sri Lanka Veterinary Association constitution, one of the objective is the welfare of our members. And also, I got a request from Dr. Lushanthi Kannangara to have a collaborative webinar with Sri Lanka College of Physicians. Because of all these reasons, we decided to conduct today's webinar on 1st of May. So before starting the procedure, first I must call our President, Dr. Susantha Mallavarachchi, to welcome all the resource persons and the participants. Over to you, Dr. Susantha Mallavarachchi.
Thank you, Dr. Jamari, our secretary, and good evening to everyone. This is a special day because you know the May Day is a free day for everyone. I hope that it is not disturbing all the professionals, but it is a very important topic we are going to discuss today, especially because sharing knowledge is the fundamental act of friendship, because that is the way to share something without losing something. That is not said by me, but Richard Stallman, that is a very famous software engineer. And according to that, we thought of sharing knowledge among our professionals, because Sri Lanka Veterinary Association is the apex body of veterinarian in Sri Lanka, and we have more than 1,200 membership. But today all are not joining because they have different personal agendas also, because today is holiday. However, there will be interested audience to join this session. And first of all, I must welcome all our professionals from medical profession on accepting our invitation today, especially the President of Sri Lanka College of Physicians, Professor Arosha Disanayake, and also resource persons, Dr. Naomali Amarasena, Senior Consultant, Cardiologist, Jayewardenepura Hospital, General Hospital, and Dr. Manilka Sumanatilleke, Consultant Cardiologist, National Hospital, Colombo, and especially our moderator, Dr. Lushanthi Kannangara. He is one of the sister, I think, not one of the sister of our secretary. And I'm really happy that you are joining also as a moderator. She is a consultant physician from the University of the Teaching Hospital of Karapitiya. So I welcome everyone for this session, especially from our profession. We have professors and also faculty staff from the University of Peradeniya, veterinary faculty, and also from the department, and also my committee members and all the members of Sri Lanka Veterinary Association. I welcome you all for this session. I'm sure you can learn a lot of things, because you know during the COVID situation, most of us didn't move out of the our own places, and we used to consume more food. So that is one of the important thing we have to consider, because in consuming food, that is, we are asking some other non-communicable diseases to come in. So then I think you can learn a lot and you can share your knowledge, and also you can ask any questions. And there's a basic ground rule that everyone other than the speaker need to keep your mic muted, not to disturb other audience and also the presenter. And I am sure that you will get a lot of knowledge. And I must thank also for the Ceylon College of Physicians for accepting our invitation and being volunteer to this session. Thank you everyone again, and I am really happy that you are joining my members, my association members. And I hand over to our secretary, Dr. Jamari. Thank you.
Thank you, Mr. President, Dr. Susantha Mallavarachi. Next, I would like to invite Professor Arosha Disanayaka, President, Ceylon College of Physicians, to deliver a few words. Over to you, Professor.
Thank you very much, Susantha and Chamari. It is a great pleasure. It's a great pleasure to be with you and your society this evening. I must explain what the objectives from the CCP perspective is by taking a few seconds of your time. Now, when we set out our program in 2022, one of the objectives was, now CCP is generally, just to tell you all what the CCP is, we are the apex body for physicians, not the surgeons of medicine. And we have in our midst, all subspecialties like cardiologists like Dr. Naomali Amarasena, endocrinologists like Dr. Manilka Sumanatilleke, neurologists, respiratory physicians, internal medicine physicians, everybody is part of our organization. So we are the apex body for physicians. So we collaborate traditionally very closely with maybe, like our own subspecialty colleges, as well as we collaborate with surgeons and obstetricians, etc. But this year we thought we will go a little beyond and try to build bridges and bridge links with other professionals who are not directly in the field of medicine. So with that objective, we started off with some very productive webinars like this with the Bar Association of Sri Lanka. And now we've made some very great friendships with members of the Bar Association. And this is the second stop in our journey with the Sri Lanka Veterinary Association. So I hope that we will all become very good friends in time to come. And then we will share we will support each other, be friends, and this will be a lasting relationship between the two associations in the years to come. So that's our objective. And then from a CCP perspective, I'm very grateful to Dr. Lushanthi Kannangara, who is a council member of the Ceylon College of Physicians, who coordinates, she heads this program. She's the boss of this program. She plans and coordinates all activities of this program. And so far, she's been doing an absolutely brilliant job about it. And then again, from the CCP side, I'm so glad that we have two of the most eminent consultants in their own respective fields to speak to you all today. Very senior consultant, my teacher, Dr. Naomali Amarasena, cardiologist. And then, of course, Dr. Manilka Sumanatilleke, who is my colleague. We trained as specialists around about the same time to speak to you on two very important subjects, heart disease and diabetes. So that's the CCP team. And I hope this will be a very productive and useful session for all of you as well. And then I wish to extend my heartiest thanks to Dr. Chamari Kannangara for coordinating all these efforts. And of course, Dr. Susantha Mallavarachi for providing the platform for us to join hands in friendship. The theme for the CCP 2022 is bridging, crossing divides and bridging gaps. And I think this is an absolutely wonderful moment where we cross traditional divides and build bridges with a very important friend, the Sri Lanka Veterinary Association. Thank you very much for your patient listening. Lushanthi, you may take over and conduct the rest of the program. Thank you.
Thank you, Professor Arosha Disanayaka. Thank you very much. Next, I will briefly introduce about our resource persons today. First, I will introduce Dr. Naomali Amarasena. She is a consultant cardiologist, and she is qualified in. She has MBBS, MD Colombo, FRCP London, FACCP, FRACP London. Dr. Naomali obtained her medical degree from University of Colombo, and after that she obtained her MD medicine degree from University of Colombo. And having selected the cardiology as her specialty, she had her initial training at the Institute of Cardiology, National Hospital, Sri Lanka. After that, she spent 3 years at John Pacific Hospital, Oxford, and she successfully obtained the MRCP in 1992. After her return, she joined cardiology unit, Sri Jayewardenepura Hospital, and she was the first cardiologist at the hospital of Sri Jayewardenepura. As there was no cardiac unit at that time, she was able to establish the fully equipped cardiology unit, and currently she is working as the senior cardiologist at Sri Jayewardenepura Hospital. Dr. Naomali also a past president of Sri Lanka Ceylon College of Physicians, and yes, she held that position in 2009. Next, I will introduce about Dr. Manilka. Dr. Manilka Sumanatilleke. Dr. Manilka Sumanatilleke has MBBS, MD Colombo, MRCP London, MRCP Diabetes and Endocrinology UK, FRCP Edinburgh, FACE USA, FSLCE Sri Lanka, FSCCP Sri Lanka. Dr. Manilka Sumanatilleke is currently working as the consultant endocrinologist, National Hospital of Sri Lanka. Dr. Manilka is the Vice President, Diabetes Association of Sri Lanka, and former Chairman, Sri Lanka Diabetes Federation, past Vice President, Sri Lanka Medical Association, past President, Sri Lanka College of Endocrinologists, former Secretary, South Asian Federation of Endocrine Societies, and Dr. Manilka trained in endocrinology at the National Hospital of Colombo and St. Bartholomew's Hospital, London, UK, and he has published many peer-reviewed journals. Next, I will introduce our moderator, Dr. Lushanthi Kannangara. Dr. Lushanthi Kannangara has obtained her MBBS from University of Colombo, Faculty of Medicine, MD Colombo, MRCP UK, MRCP London, MRCP in Geriatrics, Diploma in Writership and Communication from University of Sri Jayewardenepura. And she is now working as a consultant physician at the teaching hospital, Karapitiya. So to start our today's program, next I will hand over this session to our today's moderator, Dr. Lushanthi Kannangara. Over to you, Dr. Lushanthi. Thank you.
Thank you very much, Dr. Chamari Kannangara, for the kind words of introduction. Before commencing the first lecture, I would like to remind the audience that you can send your questions to our chat box or Q&A box, and we will be answering the questions at the end of two lectures. Without taking much time, I would like to invite our first speaker for today, Dr. Naomali Amarasena. Senior Consultant Cardiologist, Sri Jayewardenepura General Hospital. Dr. Naomali Amarasena, Madam, over to you.
I'm trying to share my, I shared it perfectly well earlier.
You're allowed.
Click on that green arrow.
Yeah, no, I think is that okay?
Yes, madam, we can see.
Right. Okay.
You, I think this is not the first slide. You have to go to the beginning.
Yes, I know. I understand. It's not moving. That's why.
You can stop sharing and restart again. It's
okay.
working.
Anyway, seems to be okay. Is that all right?
Yes, madam.
Yeah.
We can see.
I'm back in the first slide. Okay. Right. I'd like to thank the Sri Lanka Veterinary Association for inviting me to make this presentation, and also for Dr. Lushanthi for organizing everything, and all of you for your kind words of introduction. So I'm talking about a topic which we're all interested in, because we all want to know how to prevent a heart attack. And so basically, what is heart disease? The heart is the most hard-working muscle of our body. It pumps 4 to 5 liters of blood every minute during rest. And it supplies nutrients and oxygen-rich blood to all body parts, including itself. So the coronary arteries are essentially the arteries which surround the heart and keeps it nourished with blood. And the main ones being the left and the right coronary arteries, the left one being the larger artery, which divides into 2. Seems to be going all over the place. Yeah. So what happens is, over a period of time, fatty deposits called plaque builds up within the artery walls, and the artery becomes narrow. And this is what is called atherosclerosis. And when this occurs in the coronary arteries, the heart does not get sufficient blood. And the condition is called coronary artery disease or coronary heart disease. It is a myth that these fat deposits when you're old. It actually starts when you're about 2 years old. So you find initially in your first decade, you get lipid-rich macrophages, which are called foam cells, and they develop into what is known as a fatty streak. Then you get an intermediate lesion. Then you get the atheroma buildup. And then fibrosis sets in and you get a fibrous plaque. And finally, you get a complicated lesion where for some reason, the fibrous cap ruptures and a clot forms, and that can block the entire artery, causing a myocardial infarction or heart attack. So do other organs also get affected by the same process? Yes, they do. For instance, if the brain arteries get affected, you get a brain attack or an ischemic stroke. The same thing can affect your legs, the arteries to the legs, and that gives rise to what is known as intermittent claudication. And the coronary artery disease itself can manifest in different ways. You can just get a chest discomfort relieved by rest, which is known as angina, where the artery doesn't block off completely. Or you can get a heart attack, where it blocks off and causes damage to the heart muscle, or worse comes to worse, sudden cardiac death. So what are the symptoms? Essentially, most of the time you don't have any symptoms at all. And as I mentioned earlier, you have angina. Now, if you get a myocardial infarction, again, you get actually certain instances which are called, which are essentially silent heart attacks. And this is very common in diabetics, which Dr. Manilka will talk about. But when you do get symptoms, it can take the form of a severe tightening chest pain, mainly behind the breastbone or the left side of the chest, and it can radiate along the arms to the neck, the jaw, or even to the back. It can also be associated with heart failure or with irregular heartbeats. And then, as I mentioned earlier, the final blow to you would be sudden cardiac death. So as the symptoms, it's a kind of, it's not a pain in the fact that it's most pains are like what you get if you go and hurt your arm or something like that, where you get an excruciating pain. This is more discomfort. It's like a pressure on your chest. But of course, this discomfort can build up to the extent that there are people who describe it as if an elephant is kind of pressing his leg on your chest. It can be that bad. And also it can be associated with various other associated symptoms like sweating. You can feel lightheaded because your blood pressure might be dropping. You're very anxious at that time and can look pale, and you'll be having palpitations. There's a symptom which is described in Latin as angor animi, or fear of impending death. This you see or you feel only with heart attacks. I mean, you get patients who have got renal colics and biliary colics and things like that, who are literally rolling around in the bed, but they never really think they're going to die. So if you know somebody who's having these symptoms, just rush them to emergency. But before you do that, give them an aspirin to chew. I will talk about that later. So how big is this problem? It is the #1 killer disease worldwide, with 12 million deaths annually. There has been, however, in the last 30 years, declines in the developed countries because of rising health awareness and government programs. Unfortunately, an alarming increase in developing countries, particularly South Asia. So the reason being that South Asians are more susceptible. It seems to be in our DNA, and much more than the Americans, the Chinese, a lot more than the Japanese, and it also occurs at lower cholesterol levels. You also get the disease at a much younger age, and it follows a more severe and a more malignant course. And it's 3 times higher rate of a second heart attack and a 2 times higher mortality than the Caucasian whites. So you have a genetic predisposition as well. Also, we have a very poor handling of fats and what is known as the metabolic syndrome, which again will be described later. Diabetes, obesity, high blood pressure, and coronary artery disease are what results from this poor handling of fats. Then there are environmental insults like urbanization and sudden change in lifestyle. So there are what you call modifiable risk factors and what you really cannot help. For instance, you can't help your age, and men more than 45 and women more than 55 are more susceptible. Men more than women, and it also different races have got different risks, and also you might be having a bad family history, which is important. But however, you can help a high cholesterol, smoking, high blood pressure, diabetes, obesity, alcohol, and physical inactivity. People with a family history of coronary artery disease also have other risk factors. That is also important because it has an exponential effect. And you can have high cholesterol, high blood pressure, etc. Then also, you generally find that these food and exercise habits and exposure to smoking run in families. You find that if the father is obese, the son also might be obese. So the thing is, you have to change your lifestyle and modify these risk factors. So basically, you eat right, you exercise, don't smoke, control your blood pressure and diabetes, and you decrease your stress levels. Now, what about cholesterol? Everybody needs cholesterol. It serves a vital function in the body. It circulates in the blood. However, too much cholesterol can deposit in the arteries in the form of plaque and block them. And you won't get a symptom of high cholesterol till you get your first heart attack or you develop angina. So, where do all these things come from? There are 2 sources. One is the food, but quite a lot of cholesterol is made in your body. And that happens a lot with the genetic crowd. people, the ones who have the genetic predisposition, the familial hypercholesterolemia patients. I mean, many of them are actually eating very good diets, but they still can't stop their cholesterol from rising above 500. So the sources are all foods containing animal fat and meat products. There's no cholesterol in vegetables. And you can see that it gets into through the digestive tract, and the cholesterol produced in your body and the cholesterol from the food you eat are the sources which can build up in the cholesterol in your bloodstream. Now, you have heard of good and bad cholesterol. Well, LDL is known as the bad cholesterol, which has a tendency to increase the risk of heart disease, and it's a major component of the plaque that clogs the arteries. HDL is known as the good cholesterol. It's higher in women and increases with exercise and helps carry some of the bad cholesterol out of the arteries. Those who are overweight, that is 10 to 30% more than their body weight. If you're obese, you have 2 to 6 times the risk of developing heart disease. There are different waist to hip ratios in the different communities. Essentially, this is the normal waist to hip ratio, which I'm describing, less than 0.85 for women and 0.95 for men. But again, it varies according to different communities. The other thing which matters is, do you look like a pear or do you look like an apple? Because that also matters. Apple shapes are at high risk. The pear-shaped paunch stores fat on the hips and thighs just below the surface of the skin, while the apple-shaped paunch stores body fat around the abdomen and chest and surrounds the internal organs. So that is the more dangerous type of body shape to have. The other thing is physical inactivity. Unfortunately, many of our people are like that. They like to relax. And the modern day conveniences also have made things worse. For instance, you don't even get up to change the TV channels. You've got a remote. Now, what about cigarette smoking? It increases the blood pressure. It decreases the good cholesterol, which is the HDL. It damages arteries and blood cells. It increases heart attacks. And cigarette smoke contains more than 4,000 chemicals, and 200 of these chemicals are poisonous. So, other thing is, don't think that just because you're smoking that it's your body and your cigarette and why should anyone else bother? No, you are affecting all the people around you. All those passive smokers can also get lung cancer. They can also get heart disease. So please at least think of your family and refrain from smoking. Now, alcohol consumption is not directly related to the coronary artery disease I'm talking about. Because in small quantities, it used to be regarded as being beneficial. In large amounts, however, it adds fat and calories and raises the blood pressure. If you have 4 drinks a day, you won't end up with the cardiologist, but you're more likely to end up with the gastroenterologist. It's also a very fine line. It's worse for women because they tolerate alcohol much less than men. Recently, that is in January 2022, there was a World Heart Federation policy brief. And based on an article published in 2018 in the Lancet, the policy brief was that alcohol consumption of any amount, even as little as 1 glass of wine per day, leads to a greater risk of developing cardiovascular disease such as heart failure and stroke. This is probably more related to its association with high blood pressure. At any given cholesterol level, diabetic persons have a 2 to 3 times higher risk of heart attack or stroke. And they're also more likely to die of a heart attack than a non-diabetic. Risks of sudden death from a heart attack from a diabetic is the same as that of someone who has already had a heart attack. So this risk operates across a continuum. There is no clear-cut line. And blood pressure, cholesterol, overweight, smoking, they are all risks and they're multiplicative, where many risk factors coexist and they often cluster together. And the majority of events rise in individuals with a moderate elevation of many risk factors than from a marked elevation of a single risk factor. For example, you might be having a cholesterol level of about 300, but no family history, no high blood pressure, no diabetes, not overweight, and it's quite possible that you may never get heart disease. While those who have got cholesterol levels of say 270, blood pressure of 150, 90, things like that, which are all moderate, but they add up together. And as I said, it has an exponential effect and of developing heart disease. This is an interesting app and very useful actually. You just add on your various features like your cholesterol, your high HDL, LDL, your age, and so on. You can get your risk. This is right. I have found it rather useful because many people panic when they find that their cholesterol levels are more than what is stipulated in the report you get, where you get these double stars, which actually terrify people. Many of those people actually do not need anti-cholesterol medication. They do not need cholesterol-lowering drugs. So the thing is, it's sometimes useful to see what your risk is. And if according to the risk calculation, you're having a high risk of developing heart disease, then there is an indication for starting cholesterol-lowering medication. But most of the time, when your levels are a bit high, lifestyle modification is the way to go. So basically, you have to, everybody protects their own families. You look after your house, you get security systems, you do everything. You're protecting yourself and your family is second nature. But how much do you actually protect yourself from heart disease? For instance, if it's a car, you want the best mechanic. And you will ask around and find the best one. But for your body, you follow hearsay, advice from friends, local quacks, just about anybody. And they decide for the worst. There are a lot of people pride themselves on saying, I never had a test or retest. They've never been to a doctor. I don't like taking medicines. When my blood pressure is normal, I stop my medicines. And there are so many miracle doctors. It's not just for like the Dhammika Penny. You get miracle doctors for everything, and particularly for heart disease. They all know how to treat it. So many people think that they're their own doctor, and it's also cheaper. So they do what various people tell them to do, which is actually quite a big mistake. Now, you were talking about, in your introduction, I believe the president of your association was talking about food. Well, let's talk about food because it's quite interesting. One is oils and fats. Certain fats are essential for good nutrition and health, and they also provide essential fatty acids which the body cannot manufacture. They also act as insulators to maintain body temperature, and they improve the palatability of food and promote digestion. They provide the greatest energy output per gram of any food source, and they also carry the fat-soluble vitamins like A, D, E, and K. Now, this slide actually shows the different types of fats, and you have saturated, monounsaturated, and polyunsaturated. And you can see the percentage. The red is the saturated, and coconut oil carries a huge percentage of that. And same with butter, beef tallow, palm oil, lard. Olive oil carries a lot, and canola oil and peanut oil are mainly monounsaturated, while the polyunsaturated, which is the green column, you get in flaxseed oil, sunflower oil, corn oil, soya oil, and so on. So this is kind of the composition of the different types of fats and oils you use for your cooking. So what are saturated fats? Saturated fats basically means that the fat is saturated with hydrogen and they're solid at room temperature. For example, lard. They are bad for you because they increase the levels of LDL, decrease the HDL, and increase total cholesterol. So anyway, the American Heart Association recommendation is that you should limit your intake of fats to 7 to 10% of total calories. Polyunsaturated fats are unsaturated fats, which are liquid at room temperature and in the refrigerator. They also help the body to get rid of newly formed cholesterol. The monounsaturates are liquid at room temperature but start to solidify in the refrigerator, like canola, olive oil, peanut oil, and avocados. And they decrease the total cholesterol and lower the LDL. Trans fatty acids are the unsaturated fats which have hydrogen added to them to give them a longer shelf life, but they tend to raise total and LDL cholesterol and lower the HDL. So where do you find them? You find them in fast food restaurants and various commercial baked goods like donuts, potato chips, cupcakes, etc. What do you mean by these omega-3 fats? That's a type of polyunsaturated fats. They consistently lower the serum triglycerides and may also have an effect on lowering blood pressure. And you find them in oily fish, such as salmon, tuna, and herring. And it's also available, as I'm sure you all know, it's as a supplement. So, what kind of food should you eat? First of all, look before you eat. Try to eat a variety of fruits and vegetables every day. 5 servings, which are naturally low, because they're naturally low in fat and high in vitamins and minerals and antioxidants. Try and eat colored vegetables and fruits. Eat a variety of grain products. Choose your non-fat or low-fat products and use less fat meats like chicken, fish, and lean cuts. And switch to fat-free milk or toned or skim milk. You limit your intake of foods high in calories and low in nutrition, including foods like soft drinks, candy, and junk food. And limit foods high in saturated fat, trans fat, and cholesterol, and eat less than 6 grams of salt a day. And have no more than 1 to 2 alcoholic drinks a day if you are a regular drinker. So, avoid foods, or avoid or limit foods rich in cholesterol and saturated fats, egg yolk, fatty meat and organ meat, butter chicken, butter fried fish, milk fat, ghee, butter, cheese, ice cream, full cream milk, hidden fats like bakery biscuits, patties, cakes, and pastries. In fact, if it tastes good, just spit it out. Eggs are a bit controversial because now it's been shown that even eating a full egg actually does very little harm and does you quite a little bit of good as well. There's no question about it. There's cholesterol in the egg yolk. But sometimes the body acts in different ways depending on exactly in which form you take things. So don't avoid your eggs very much. Just don't take too much of it. You can take any amount of the white of egg, but the yolk, don't avoid altogether, even if you're having heart disease, because it carries the best quality amino acids that you can find. The other important way to prevent heart disease is exercise. You maintain a level of physical activity that keeps you fit and matches the calories that you eat. It serves several functions in preventing and treating those at high risk. By reducing the incidence of obesity, it increases the good cholesterol or HDL, lowers the LDL and total cholesterol, and helps control diabetes and hypertension. Mortality is halved in retired men who walk more than 2 miles every day, and regular exercise can halve the risk of heart disease, particularly in men who walk briskly. Someone who is inactive has a great risk of having heart disease as someone who smokes, has high blood pressure, or has high cholesterol, and exercise significantly reduces the chance of diabetes and stroke. With regular exercise, blood pressure in those with hypertension is reduced by as much as 20 millimeters mercury. So you maintain a level of physical activity that keeps you fit and matches the calories you eat, and it serves several functions in preventing and treating those at high risk. So moderate to intense physical activity for 30 to 45 minutes on most days of the week is recommended. And what fits your busy schedule better? Exercising 1 hour a day or being dead 24 hours a day. So therefore, please you encourage everyone you know, start walking. Half an hour a day is not much. And all you're asking people to do is just walk on a flat surface at your pace, wearing a good pair of shoes and not slippers which don't have a backstrap, because many people go and injure themselves by just wearing, taking the easy way out and just wearing their, butter slippers and walking around. The best exercise you can have also is walking. You do not need complicated exercise machine or sweating it out in the gym. You just walk. Now, the risk of heart disease starts decreasing within 24 hours of quitting smoking. And within 1 year of quitting, coronary artery disease risks decreases significantly. And within 2 years, it reaches the level of a non-smoker. Your smell and taste also improves within days. And within 3 months of quitting, the smoker's cough disappears in most people. There are different ways of stopping. There are nicotine patches and so on. But the best way is to just stop completely yourself and be convinced that you have to stop. The other advantage of stopping any of the, or controlling any of these risk factors are they don't just affect heart disease, they affect a lot of things. That's just stopping cigarettes. You not only improve the heart, you also reduce cancers, you reduce chronic respiratory disease, and your oral health improves. Alcohol reduces cancers, and it's good for your mental health. So like that, most of these things are interconnected. And therefore, it's important that you advise everyone, of trying to control these modifiable risk factors as best as you can. Now, what is the number that you need to know? That is really your cholesterol levels. The total cholesterol of less than 200, LDL of less than 100, HDL of more than 40, or triglycerides more than 200 is what is regarded as desirable in somebody who does not have any kind of heart disease. So if you just keep them under control, most of the time, you should be fairly okay. And the benefits are that a 10% reduction of your cholesterol produces a 20 to 30% decline in coronary artery disease. So all adults more than 20 years must get tested. If normal, test again. And after 5 years, if elevated, work towards normalizing these levels with lifestyle modification and drugs as needed. You should have your blood pressure checked at least once every 2 years. If there are no symptoms, because there are no symptoms to tell you that you have high blood pressure. You start getting headaches usually when the blood pressure is quite high, and sometimes not even then. So although optimal levels are 120/80, you can move a little this way or that way. There are some people who just have low pressures, which are just normal to them. I mean, anything less than 140/80 is reasonably okay. If it's high, again, you modify your lifestyle. Diet, get your weight down. With every kilo, you drop a couple of points. Exercise and restrict salt. And do not stop your medication without consulting your doctor, even when your blood pressure becomes normal. The sugar part, I'm going to leave to my colleague. And when it comes to heart disease, basically don't get disheartened. Science has made significant progress. What you have to do is to just monitor your risk factors much more aggressively. Eat healthy, walk regularly, watch your weight, quit smoking immediately, keep your weight under control. In addition to improving your heart health, these measures are sure to enhance your appearance as well. So you adhere to your medicines and listen to your doctor. Now, screening is an important way of finding out whether you are having underlying heart disease or not. So there are different ways of screening. The ECG is, if you do get chest pain at any given time, it's a good thing to get your ECG done and show it to somebody. Then there are other tests like exercise tests, where you go on the treadmill with an ECG fixed onto you, and at certain levels of exercise, if there are ECG changes, that might mean that you're having some kind of coronary artery disease. The coronary angiogram is not a screening tool, it is a diagnostic tool. And it shows specific blockages in your arteries. There are other investigations also. For instance, blood tests, where you evaluate your kidney and your thyroid functions, because sometimes if you're low in thyroid, you might have high cholesterol and presence of anemia. Chest X-ray, the echocardiogram, which gives you a graphic outline of your heart movements and shows how well your heart pumps. Then the stress echo, CT scans, and nuclear cardiac scans. The exercise ECG checks for changes in your heart while you're exercising. And a resting ECG is always done before. It's not always accurate. I mean, it's essentially a screening test. And particularly in women, because you tend to get a lot of false positives, and where you go and do an angiogram and then find that they're actually okay. So you might need other tests. This is the multi-slice CT or a CT coronary angiogram. You can do a calcium score, because a high calcium score is shows that you have a predisposition towards heart disease. And the CT coronary angiogram, where it virtually, you can see the arteries, it reconstructs the images, and although it's not as good as an invasive coronary angiogram, it is on the other hand non-invasive, and therefore, especially in people where you have a strong index of suspicion, but who have not had any heart attacks and so on, who do not need any kind of intervention, it's a very good tool, because it has got a good negative predictivity. Basically, if it is normal, you're actually quite normal. So there are these different types of investigations, like the magnetic resonance, the MRI, and sorry about that. Yeah, most of these, yes, this is a multi-slice CT, and you can see that it has a very high sensitivity rate and a very extremely high specificity rate, with a good negative predictivity of 99% and a positive predictivity of about 78%. The nuclear cardiac scan, again, you take images before and after, and you inject an imaging agent before going under the camera. And it basically has an accuracy of about 90%, but it's a rather expensive test. Now, there are different types of fats, which I spoke about earlier. So I won't discuss this as part of the management. But as I said, stick to more the monounsaturates and the polyunsaturates and your omega-3 fish oils. And it's a good thing. I mean, you can't be eating the same thing all the time. So what you can do is to rotate the oils or have a mixture of oils. Something's going on somewhere. There seems to be some problem here. Let's see. Okay, anyway, I think we are, yes. So this gives you a summary of the different types of investigations. I'm sorry, these things got all mixed up. And as you can see, the CT angiogram gives you this negative predictivity of 99%. But if you look at all these tests, the stress echo is only 70 to 80%. Exercise tolerance test or the stress testing, which you normally do, is much less. But the cardiac catheterization has a sensitivity and a specificity of 100%. Now, how do you do that? So you have what is called a cardiac catheterization laboratory. This is the cardiac cath lab at Jayewardenepura, actually. And it is an invasive diagnostic test. And this is the kind of images you see. You inject a contrast, and as you can see here, you're seeing a blockage in the left coronary artery, a critical blockage. And here you're again seeing another blockage in the right coronary artery. So what happens when you do have a blockage? You have different ways of handling it. Sometimes you have just moderate blockages and sometimes you have critical blockages. Now with the moderate blockages, you do not have to do a bypass operation or an angioplasty. Most of the time, lifestyle modification and medications are good enough. And the lifestyle modifications we described in detail. The medications are supposed to enable you to achieve those particular lifestyle modifications, like you get your cholesterol down to specific levels when you're having heart disease compared to those who are not having heart disease. You control your blood pressure and you control your diabetes. The coronary revascularizations are that there are two major ways of doing so. One is coronary angioplasty, where you put in a little tube or a stent, which enlarges that blocked artery and helps the blood to flow well, or you completely bypass the blocks, which is the coronary artery bypass surgery. So coronary artery stenting, now this is what you can see here is a stent, and it's similar to the, it's like a little, what you might see in a ballpoint pen, slightly more complicated. So when you do stenting, it's actually similar to coronary angiography, and the narrowed coronary artery is crossed with a wire and a balloon is passed across the wire. The balloon is inflated and deflated and removed. And then the stent, which is an expandable metal tube, it's positioned and expanded to keep the artery open. So this is the way you actually approach it. There are two ways. Earlier, it was always done through the femoral artery, but now most of the cases we do are through the radial artery, where you puncture it and you pass a little wire and you pass a little tube, and through that tube you pass the bigger, longer tubes to the heart. And here you can see that this is an artery which is clogged with plaque, and here you have passed your balloon, and this is the stent, which is before it is expanded, and how you have an expanded stent, and then you have the stent in place. Now this stent is not removed, unlike in the field of urology where you actually remove stents. This stent actually gets incorporated into the artery, and you get endothelialization of the stent over a period of time. It becomes actually part of the artery. And here you can see a case of stenting. You can see it's critical narrowing here in the left anterior descending artery, which goes in the front of the chest. This is one of the most dangerous places to get a heart attack. And this is, you can see after the stenting that it's quite open. So what about the risks involved? Most have no trouble at all. But however, while you're doing the procedure, sometimes the artery which is being treated can suddenly close off. And however, now we have got various tricks up in our armory, and we can get around this situation. Earlier, urgent bypass surgery used to be done, particularly before stents came, when we were doing just plain balloon angioplasty. But so our urgent bypass surgery may be needed, but however, it's very rare. Now, will the angina return after you've done the stenting? Most actually have no further problems, but in some cases, the coronary arteries may narrow again within 3 to 6 months. Sometimes people think that once you've done this, everything is fine, it's all over. Just you have to remember that both angioplasty and bypass surgery are essentially plumbing jobs. You have just cleared the artery, but you haven't treated the cause. You have to treat your cause. You have to control your diabetes. You have to control your blood pressure, and you have to keep your cholesterol under control, and you certainly shouldn't touch a cigarette. So that's one of the main reasons. The other reasons is actually people just stop taking some of these drugs just because they don't like taking drugs. Other thing is, you might be just unfortunate. You might be having a very malignant kind of course of disease. This happens with many of the young people. Yeah, because before you can turn around, you had just one artery blocked, and then the next day, in about 5 months, you get all 3 arteries blocked. And so even the one which is attended to with a stent can block off that way. However, these drug-eluting stents have reduced the chances of narrowing quite a bit because it reduces that plaque buildup after stenting. Because what happens is the stent itself is a foreign body, and the body doesn't really like it. So you find that there are excessive cells which are formed, which tend to cause a re-narrowing. However, with these drugs which are used both in kidney transplant as well as in cancers, they reduce the cell division, and by doing that, it reduces this kind of restenosis. bypass surgery is an operation which bypasses the blocks. And what you use here, you might be using an artery which is going inside your in your body, which is really a branch of the subclavian artery which goes to your arm. And this subclavian artery, this internal mammary artery, which comes off the subclavian artery, goes behind your breastbone or your sternum. And this is what is used to usually graft the left anterior descending, which is the artery I showed earlier. You can also use the saphenous vein from your leg or an artery from inside your chest and forearm. And the bypass is sewn to the coronary artery beyond the narrowed point. As you can see, this is a diagrammatic sketch with the bypass grafts. You see that upper part is fixed to the aorta, while the others are fixed to the beyond the blocks of the coronary arteries. This is an actual artery, actual graft, and these tubes are really these grafts which are putting in. And you can also see that this particular patient has had a heart attack because you can see this reddish area on the surface of the heart, which is the site of a myocardial infarction. So heart disease is often avoidable. Following a heart-healthy lifestyle doesn't have to be complicated. It doesn't mean you need to live a life of self-deprivation. Instead, you find ways to incorporate heart-healthy habits into your lifestyle, and you may well enjoy a healthier life for years to come. So don't wait for a heart attack to take action, and don't wait for a second life, as we are not cats. So thank you. Thank you for your patient listening, and I apologize for those little hiccups in the presentation.
Thank you very much, Madam, for the comprehensive lecture on heart disease. Next, we have another important speech on diabetes. Our second speaker for today, Dr. Manilka Sumanatilleke, Consultant Endocrinologist, National Hospital of Sri Lanka. Over to you, Dr. Manilka.
Thank you very much, Lushanthi, and the Sri Lanka Veterinary Association and the Ceylon College of Physicians. I hope I was in another place, but my Wi-Fi was faltering, so I had to shift to another place, and you might not see me well, but I'm sure you can see the slides clearly. So talking about diabetes, I want to, this Sunday evening after a previous lecture, you have got a lot of subject matter. I'm going to show you few photographs to start getting to the topic of diabetes, to understand the pathophysiology and what's happening with the ever increasing numbers of patients with diabetes. So this is the actual photograph of Gall Road in early 1900s, number 50 Gall Road. Now, if you look at this may be the situation now. These are two people, even in remote areas. If you go to Dambana, you might see this. They have gone hunting for their food, and they are preparing the meat. But what is the situation in the cities and our children? They indulge in lots of energy-dense, high-calorie foods which are freely available in the form of fast food and these days. This results in obesity, and what I call this generation, the last 40 to 50 years, as the modern evolution of the man. So from this stage to the modern man, it took millions of years, and your genes have changed. But from here to here, it's only couple of decades, and it's all to do with your lifestyle changes. So that's what I'm trying to allude through this set of photographs. So diabetes, as you know, the numbers are staggering. So as of now, there are nearly 450 million diabetics all around the world, and out of which a large proportion of them is in our region. Southeast Asia is called the hotbed of diabetes. I'm talking about mainly the commonest type, the type 2 diabetes. So, and the expected rise by 2045 is 84% in our region compared to, say, Europe, which is only a 16% increase is expected. So you can see the scale of things and the importance of controlling. The prevalence in Sri Lanka, as in a 2007 study, which was the last done in the whole island, not the whole island, only 7 provinces except the north and east, was 10.3% in adults. And the Western province as a province had 18.6% of adults having diabetes, and Uva was the least with a 6.8. But a smaller study done in Colombo more recently showed a nearly a 27% prevalence of diabetes in that small group, highly urbanized group. You cannot apply this to the whole island, but in cities with changing lifestyles and lots of fast food, unhealthy habits, not exercising, this is the scale of things. So it's nearly about 20% definitely. So what is diabetes? This has been coined from 2 words, both Greek and Latin. So diabetes in Greek means to pass water like a siphon, and mellitus means as sweet as honey. So you're passing very sweet urine, basically lots of sweet urine, which is also 2 cultures at the same time. In Sanskrit and our part of the world, it was called Madhumeha, same meaning, or Diyavadiyawa in Sinhalese. So as you all know, physiology, I thought I would add a little bit of physiology for your understanding. The role of insulin in glucose disposal. How does the insulin hormone work in controlling the blood sugar levels? So insulin acts as a key which allows the glucose to enter your liver, fatty tissue, and the muscle. And if the insulin is not working properly, or there is a deficiency of insulin, the glucose digested from your bowel and which enters the blood doesn't enter these organs effectively or efficiently, and it remains for a prolonged period of time in your bloodstream. That is when you call the situation as having diabetes mellitus. So what are the classical symptoms of diabetes? Fatigue, nocturia, weight loss, unintentional weight loss, visual disturbance, infections, polydipsia, and polyuria. So all of you are familiar with these symptoms, and this cartoon may give a better idea. And although your sugar levels are high and you are losing weight, there is excessive hunger as well associated with diabetes in most people, and there will be blurring of vision, numbness of your hands and feet, and wounds which are not getting better. So these are and urine infections. So these are the usual presenting complaints. Diagnosis of diabetes, it's very easy. It's a single blood test. With a single blood test, you can diagnose diabetes if the person is having these typical symptoms. 8 to 10 hours of fasting, and you do a fasting blood sugar, and if that is more than 126 milligrams per deciliter with a few of those symptoms which I mentioned earlier, we can diagnose diabetes. Even without those symptoms, if you have 2 readings of fasting blood sugars more than 126, we can diagnose diabetes. Less than 100 is normal. There is this yellow bar. The impaired fasting glycemia is 101 to 125. That is the pre-diabetic group. So this is a very important group. Even if you fall into this category, with proper lifestyle modification, diet and exercise, you can avoid becoming a diabetic by controlling your food habits and the exercise, increasing your exercise. Talking about the management of diabetes, let me diet is the most important thing. First step in the management of diabetes would be diet, and then comes exercise. A lot of people think that it's the medication that is most important. So that's wrong. There are lots of people who can manage their diabetes only with lifestyle modification or diet and exercise. Next step would be the oral medication, and the finally it's insulin injections if everything fails or if your sugar levels are very high. It's good to know this theory about metabolic memory. I think you all can grasp what I'm going to say. And the legacy effects are the new concepts that we have in the management of diabetes. What is this? The legacy effect or the metabolic memory. So there was a big study in controlling diabetes called the UKPDS, and they followed up people who were had a strict control of diabetes compared to the control group, and they clearly showed that complications of diabetes is less with good control of diabetes. And this group was followed up. After the study, they went back to their routine practices, doctors, and they were not strictly followed up or had strict control measures. And they found out the people who had good control initially later had poor control compared to the control group. Still, after 10 years, when they analyzed the initial 5 years, the first 5 years of diabetes, those who had a good control had fewer side effects, including myocardial infarctions, which you were hearing about, kidney problems, eye problems. Everything was less in those people who had a good control initially. So that is the metabolic memory or the legacy effect. What is happening there? You saw lots of slides before by Dr. Amarasena. So it's the change that high sugars damages your endothelium, the lining of your blood vessels, and that is the root cause of all the problems later in life, be it the heart, brains, nerves, or your eyes, or the kidneys. So coming to food, I'm sure you all can understand you have to choose wisely, avoid these stuff on the left side, and go for good quality proteins, less amount of carbohydrates, and high fiber or fiber-rich vegetables. Then how do we tell about the quantities? So the Zimbabwe hand jive done by the WHO was adapted to just to give a rough idea about the quantity of carbohydrates, vegetables, proteins, and the fat one should take. So as the picture depicts here, there should be fistful of carbs. Then you could take plenty of vegetables with open hands here, and the amount of protein is shown here, which should fill the size of your palm, and the amount of fat, clearly what is shown for a meal is the amount of fat that can be taken from the tip of your thumb. So you can get an idea about the configuration or the breakdown of different nutritional material that you should take. Of course, this is, I think, easier one for you, the plate method. So the Canadian Diabetes Association and world over, they say ideally, if you take a normal size plate, about 8 inches diameter, 1/4 of that plate should be filled with your carbohydrates, and the rest, other half with vegetables, and 1/4 with proteins. But in Sri Lanka, as you will understand, it's not practical, and our people won't be, they can't manage with a 1/4 plate of rice, especially for lunch. So the compromise is, at least you could say, 1/2 a plate of rice for lunch, and of course, no compromise there for dinner and breakfast. If you are having rice and curry, it should be 1/4 plate or 1 teacup in Sri Lankan terms, or 2 teacups at lunchtime, with plenty of green leafy vegetables and a large quantity of food. So a lot of people will ask whether this is good or bad, or one particular type of rice is good or bad. It all depends on this, what you call as the glycemic index. So the ones shown, these are only very few representative items that are there in this. So you can read up and check. There are lists of food available. Low glycemic index is the one which gives a value less than 55, and medium is 56 to 69, and the high ones are the sugar rich, carbohydrate rich food, which gives increases your blood sugar levels in a steeper manner. So you could choose ones in this. The most important thing is, although it's, even if you are having a low GI, let's say kurakka, it's not there mentioned there, but some people have 2, 3 or 4 rotis with just a fish curry or something. Still, your sugar levels can go up. Why is that? The glycemic load is the most important thing. The quantity matters most, then only the quality. Quality is important, but even white rice, if people have only just a cup of white rice compared to 2 to 3 cups of red rice, your sugar levels will go up more. It will be higher with the red rice because of this glycemic load. So you need to understand the thing about food when it comes to diabetes, and then choosing the correct food is very important. And if you, sometimes people take things for granted and they don't realize how much sugar or carbs are there in certain food. So you must learn to read the food labels and see. So these are, although I have covered it to be politically correct, but I am sure you can recognize them, and you can see the actual number of grams shown here, amount of sugar in each of these popular beverages that one will have. So imagine if you have 2 or 3 of these for a day, see the amount of sugar that you will be having. So because of that, the Ministry of Health some time back came out with this traffic light system, you may call it, in labeling the food, especially the fizzy drinks, according to the sugar content that they contain. So the green ones would be the best, and the red ones are the ones to avoid. And it shows the amount of sugar in each 100 ml of that beverage. So coming to the diet, we've got a rough idea about what should be the diet in a diabetic. It should be very simple, measurable, as I've shown before, achievable for that person or the patient. So it has to be culturally realistic and time bound. So you have to have a very smart dietary plan if it is to last long. So no crash diets, New Year resolutions, just stopping everything. You do that for 3 months, and within the next 6 months, you are back to square one. So that won't do. It has to be realistic for that person's social background, his economic background, and then you must choose the ideal food for that person. Regular exercise, that is a must for a diabetic, and also to prevent diabetes. Half an hour a day, 5 times a week would be a good prescription of exercise for a diabetic. Whatever you could do, brisk walking is enough. But if you are fitter, if your heart is all right, better to get it checked before embarking on any strenuous exercise regimes. Even jogging or going to a gym would be fine. Children, it's best that they get about 1 hour of exercise a day to avoid all these problems in future. So it's good to inculcate good habits with your children. The exercise culture is not there in Sri Lanka. So then if the parents do that, the children also will learn. And of course, for busy people like us, you and me, increasing the physical activity while doing your work, there are a few tricks that you could try. Parking, if you're going by a vehicle for work, you may park a block before and then walk reasonable distance to and fro from work, or taking your dog out for a walk, take the stairs instead of the elevator, things like that can be happen. And this lunch thing has worked in many countries, and officers don't get your lunch delivered to your to your desk or wherever you are working. Walk out for your lunch or take a break during lunchtime, and then get some exercise after the meal as well, walking back to your office or wherever you are. But people tend to take shortcuts as well, like this gentleman who is walking his dog. If he tells his physician, he will think he's getting enough exercise, but you can see what he's doing. Or this gentleman who is making good use of his treadmill, he's too lazy even to take the dog out. He's having a drink, probably a Coke or a drink, watching TV, and his dog is using the treadmill. Okay, there are people who don't do that and they exercise, and they say, I'm not watching my diet that much because I'm exercising. I don't go to the gym daily, and so still I'm not losing weight, or my sugars are not coming down. Why is it? You can see the scale of things. These are not typical Sri Lankan stuff I found, but you can see the can of Coke or these 2 cookies. Similar, you can allude to a piece of pizza. See the amount of calories, staggering, right? And see, to burn that much of calories, how much of exercise you have to do. For example, to burn the calories from a Coke can, you will have to walk for 23 minutes. Imagine the scale of things. If you have so many snacks and with your main meals, how much of exercise you will have to do to burn that? It's impossible. You'll have to control your intake. So when all that fails, we have many groups of drugs, actually like 11 types of drugs in the world other than insulin to treat diabetes. Metformin is the oldest and the commonest and the best first choice medication that we have. And if you have any doubts, it has no kidney side effects or renal side effects, which is a myth, and it's well proven that it's a safe drug for long-term use in diabetes. And you have the sulfonylureas, which is commonly known as glycoside or glibenclamide, you may have heard. Then there are other groups of drugs and certain other newer drugs like the GLP-1 receptor agonists, which are injections but not insulin. There are newer ones are once a week injections, so there is a lot of convenience and people lose weight with them. So these are newer drugs that are available for diabetes. Then there are older drugs like this alpha glucosidase inhibitor called acarbose, which prevents the absorption of carbohydrates, glucose from your gut. And the latest, what we have in Sri Lanka is called the Sglt2 inhibitors, empagliflozin, dapagliflozin, canagliflozin, which flushes out your the excess sugar in the urine, excess sugar in your blood in the urine. So all these drugs will help you to achieve a good glycemic or sugar control. But you should know, even if you have type 2 diabetes. So I'm mainly talking about type 2 diabetes here. As you know, there are other types of diabetes. Type 1 diabetes, mainly in children, no insulin is produced in the body or the pancreas. So they need insulin from day one. I'm talking about the type 2, the vast majority, 95% of the time, it's type 2 diabetes. And even them, the type 2 diabetes, at the time of diagnosis, 50% of their beta cell reserve, that means the insulin producing cells in their pancreas is lost. So somewhere, and they tend to, over time, especially if you don't control your blood sugars well, they tend to lose that reserve. And eventually even type 2 diabetes or non-insulin dependent, if you know the older term, they also will need insulin somewhere down the line after maybe 10 or 12 years. We can't tell an exact time period. So just to show what the problem with glucose, what we call as glucotoxicity, it can affect your eyes, kidneys, nerves, heart, your liver, and the beta cells itself. And how does it do that? It causes a reactive, oxygen species, which goes through different pathways. And I think we had a good idea about how this endothelial damage comes. So it's so many factors which causes increased clotting and decreased clotting and cell vascular endothelial growth factors, all culminating in monocyte recruitment and cell proliferation in the blood vessels and platelet aggregation and resulting in atherosclerosis. That is the main underlying pathophysiology which you all heard. So the major side effects of of diabetes would be, we categorize them according to the size of the blood vessels supplying that organ, which is microvascular and macrovascular. So the macrovascular complications would be the myocardial infarctions, strokes, and the peripheral vascular disease. And the microvascular complications would be diabetic retinopathy, nephropathy, and the neuropathy, nerves, kidneys, and the eyes. Very briefly, these are picture of the inside of eye of a diabetic. This is a normal eye. So you can see the difference. There are lots of bleeds. There are plaques, yellow plaques, which has got deposited. So this is called diabetic retinopathy. Mind you, even at this stage, a person like this will not have any pain or any visual impairment. That is the danger until it becomes bigger and suddenly you lose the vision or part of the eye will be gone. So that's the danger and importance of screening your eyes at least once a year or once in 2 years if you are a diabetic. So this is what will happen suddenly if they have a bleed. See, this is a man who is connected to a dialysis machine because commonly the commonest cause, other than in the northwestern province and those areas, diabetes is the commonest cause of end-stage renal disease in young people. This is a bad wound in a diabetic foot, but it looks really bad, but the patient doesn't feel anything. And so they just go on neglecting and they will ultimately end up with a situation like this. So the commonest cause of amputations in Sri Lanka after the war is diabetes, not accidents. So this you have heard, this person is getting a severe chest pain, he's coming to a heart attack. I think you have heard a lot, so I'm going to skip this slide, and this shows what happens in the heart when there's a block. So it's the same thing happens in the brain. You can call it even a brain attack. The changes are the same. Like in the heart, there'll be a small block in the part of the brain, blood vessel supplying a particular part of the brain. Depending on that area which is getting blocked due to diabetes, high cholesterol, and other factors which you all heard, you can get a stroke. So how do we prevent all this? So studies have shown that decreasing or controlling your blood glucose levels, all these, especially the microvascular complications, can be very well controlled if you have a good blood sugar control. So there is a measure of the sugar control, the 3 months average. It's a blood test we call as HbA1c. I'm sure a lot of you would have, you're familiar with it. So if you can lower HbA1c, usually we say keep it to around 6.5 to 7. That's a normal range. If your level is say 8 or 9, and if you lower it by 1%, these are the good effects that a person could achieve. 21% reduction in deaths related to diabetes, 37% reduction in kidney and eye complications, and 14% reduction in myocardial infarction or heart attacks. So the parameters, this is for a diabetic, mind you. If you are having diabetes and taking treatment, diet, exercise, or medication, you should try to keep your blood sugar levels anything between 80 to 110, I would recommend in Sri Lanka. And after a 2 hour after a meal, or what we call as a postprandial, you should keep it between 140 to 180. So 140 is better, but in an elderly person with lots of complications, even 180 is okay. So to decide who should have 180 and 140 and who should have 110 and 180, these are the criteria. So younger people with no other complications, those who are motivated, should strive to have as low as possible. But if you are an elderly person with heart disease, multiple problems, cancers, limited life expectancy, you could be less stringent, because it's not that they are not important, it's because trying to lower the sugar in the people with multiple complications and the elderly can cause hypoglycemia, and hypoglycemia can be catastrophic, in a short while. They can die of heart arrhythmia, what we call as a rhythm problem in the heart, or they can have a fall and have head injury. So that's why we say it should be less stringent and avoid hypoglycemia or low sugar at all times. So these are the general guidelines on how to treat diabetes, which I'm going to go through fast because it's not very important, but just for your knowledge. We start with diet, exercise, metformin. Then if that is not working, second line can be glycoside, pioglitazone, sitagliptin. There's another group of drugs. Then Sglt2 inhibitors, or even insulin. So that's how we escalate the treatment. And when you are combining these anti-diabetic drugs, we should choose drugs which are acting in different organs, as shown here. Metformin mainly in the liver, pioglitazone in the liver, muscle, and the fatty tissue, and the glycoside, sulfonylureas in the pancreas, and acarbose in the gut. So you combine these drugs, you get a synergistic effect. So metformin, I've talked about it. It acts mainly through the liver in a complicated manner. I'm not going to go through all the pharmacology of these drugs, but just to say it has some gastrointestinal side effects, and a rare side effect would be lactic acidosis. That is why we don't give metformin when there is renal kidney impairment due to diabetes. Sugar is the most toxic substance for your kidneys, eyes, and the nerves. So you have to realize that metformin is not toxic to your liver, and the drugs like glycoside and glibenclamide acts by releasing the insulin stores from the pancreatic beta cells, and they bring down the sugars fast, but they tend to lower your sugar excessively sometimes, what we call as more risk of hypoglycemia. And the pioglitazone, again, it reduces your insulin resistance, but it causes weight gain, and not the ideal in people with heart problems and very obese people. And alpha glucosidase, I have explained, it prevents the absorption of glucose from the gut. And these are newer drugs, the incretins, just for your knowledge. We have GLP-1 receptor agonists called exenatide, liraglutide, and there are once weekly preparations, the newer ones of this called dulaglutide and semaglutide. And the oral version of this group of drugs is sitagliptin, vildagliptin, and we have saxagliptin, which is not available in Sri Lanka, and linagliptin is the latest, which can be given even with renal impairment. These are interesting areas since you all know your physiology. These are gut hormones which are produced when the food enters the gut. GLP, glucagon-like peptide 1, and gastric inhibitory peptide, which causes the release of insulin from the pancreatic beta cells, and it decreases the glucagon release from the alpha cells. So twin action, which results in decreased blood glucose. So these drugs called the DPP-4 inhibitor, these incretin hormones are only active for about 3 to 4 minutes in the body when the food comes in. So this enzyme breaks down these two hormones, and these drugs, sitagliptin, blocks that enzyme which breaks down the hormone, so they will work for a longer period. Very simple change, and then that will lower the blood sugar levels on a food-dependent manner. If the food doesn't get into your tummy, the drugs will not be working, and so very minimal chance of having low sugars with these agents. So that I'm going to skip. Then the newer ones called the Sglt2 inhibitors, which are this Sglt2 receptor is the one which reabsorbs your glucose from your proximal tubule, and one will prevent the sugar being reabsorbed from the urine, and it will be flushed out in the urine along with little bit of soap. And the goals, I think I have said before, and the principles of starting medication. This is mainly for doctors, but it's good to know a little bit. So we combine two drugs if your initial sugar levels are very high, and if the sugar levels are about 300, sometimes we start with insulin and change over to the oral medications as shown here after getting a good control. So when you are combining drugs, you have synergistic, drugs you should be combined in a synergistic manner. I'm not going to talk about insulin therapy just for your interest. This was discovered in 1921. It's nearly 100 years of insulin. This is life-saving for type 1 patients, and this is our normal insulin secretion in the body. And for each meal, there are peaks, and there is a baseline secretion as well, which is needed. And we have different types of insulin: soluble, insulin aspart, lispro, long-acting insulins, isophane, glargine, all these. So it all depends on their the name, the variety depends on their duration of action by adding different substances to the normal insulin. It's the same molecule which has been combined with different substances to change their duration of action. When do you need insulin? In type 1 diabetes, when people are in a severe stage of high blood sugar called diabetic ketoacidosis, and in type 2 diabetes, when their levels are very high due to an infection or during a surgery or during a bypass operation. Sometimes after a heart attack or myocardial infarction, it's beneficial to have take insulin. So these are the short-term indications for insulin in type 2 diabetics. Plus, when they go in for OHA failure, they will also need insulin. There are different ways of giving insulin. You start with one injection. When that does not work, we give 2 injections of pre-mix insulin. Then we give 3 injections, and ultimately before every meal we give a dose of insulin, and in the night we give a long-acting insulin. So this is the escalation of insulin treatment if you happen to be a diabetic. So controlling blood sugar in a diabetic is not going to do the job or prevent or reduce their risk of dying. So as shown before, vast majority of our diabetes patients are having dyslipidemia and hypertension as well. You can see the percentage having all three, 56%. So you need to control, which was well explained before. Being glucocentric won't do your job. So you need to add what Dr. Amarasena was going on reiterating: stop your smoking, control your blood pressure, and control your lipids if you want to have a happy and a healthy life in diabetes, on top of controlling your blood pressures. Roughly the targets given by different associations, but would be HbA1c of 6.5 to 7, fasting 80 to 110, I would say, although they have given 130, postprandial 140 to 180, blood pressure of 130 to 80, cholesterol, if you are having diabetes, total cholesterol of 160 and the LDL of 100 would be a safe limit, with the triglycerides keeping them below 150 would be beneficial. And in conclusion, the novel concepts in managing diabetes would be that we don't take a lot of time to control the sugars. We have to be very proactive from the diagnosis. Within 6 months, adding 1, 2, or 3 drugs, we should strive to achieve our target level of control in a diabetic because of that memory effect which I told you before. So self-management is important. If that is where this education comes. Then there are psychological issues. People are, have a, there are satiety issues. So all these things should be addressed, and the patient-centered approach is the way forward. You need to understand the patient's economic background, social background, his wants and needs, his lifestyle, and then give a tailor-made solution with the medication, diet, and exercise for their diabetes control. Like the olden days, you can't order the medicines because you have to work with the patients, and sometimes you might have to play to their tune, get over them, and make them understand what they have to do to help themselves. But of course, there are always people like this horse, we can't make them do it. So you need to encourage your patients to stick to a good lifestyle and a good compliance with your medication to lead a happy life with diabetes. Thank you very much.
Thank you, Dr. Manilka Sumanatilleke, for highlighting the important aspects of diabetes. We have got a few questions from our audience, and still the Q&A box and the chat box is open for questions. If you have any questions, you can send to the Q&A box and chat box. First, I would like to ask Dr. Naomali Amarasena. I can't open the chat box. Now I can. Yeah. So why plaques are formed only in arteries? There is a question which was sent by Dr. Kumara.
Actually, plaques are not formed in veins. I mean, veins undergo certain types of degenerative changes, and I mean, you know that veins become varicose, they become thinned out. They have got the veins are completely different from arteries. They've got valves inside. They're thin-walled vessels, and you don't have a plaque buildup. I mean, the diseases of veins are completely different from the diseases of arteries. For instance, you get aneurysmal arteries, but you don't get varicose arteries. You see, like that, they're just two different diseases. So you won't get that kind of plaque buildup in veins. It's kind of limited to arteries.
Thank you, madam. I hope you got the answer for the question. And next we have another question from Dr. Indira Silva. Please explain the pathogenesis in few cases of myocarditis diagnosed globally after COVID vaccination. So this is not directly related to ischemic heart disease. She has asked about myocarditis, which had occurred after COVID vaccination. Is it a common risk factor for any or all organs, or do vaccine antigen chemicals have predilection to myocardia? So, madam, it's about myocarditis.
Yes. Well, myocarditis can be caused by several agents. One thing is viral myocarditis is very common. And after even influenza, that's why we tell people that they must rest the moment they get fever, because it can affect the myocardium and you can get an inflammatory response, which can lead to myocarditis. So you get it after any kind of viral infection, after some types of bacterial infection, and far more than the vaccines, you get it after COVID itself. COVID myocarditis has been quite common. And even with this recent epidemic we had of the very mild manifestation of COVID, which was the Omicron, we had many people who are coming after about 2 weeks with very rapid heart rates and all kinds of features which are suggestive of myocarditis. So it is the pathophysiology is essentially that it causes a kind of inflammatory response, which is probably due to various types of free radicals and various other types of chemicals released during the infection. Now the vaccine itself also has naturally has creates a kind of response in your body, and you do get a very small incidence of myocarditis which is associated with the vaccine. When you consider the number of people who have actually got the vaccine and the number who got myocarditis, that number is extremely small compared to the quite a significant number we saw who were getting not only myocarditis, but also myocardial infarctions after COVID, usually about 2 weeks afterwards. So it's I would say probably the pathophysiology is the same because the vaccine itself acts on your immune system and it's a kind of immune mediated reaction which you're getting, which eventually comes as manifests as a myocarditis.
Thank you very much, madam. And
I add a little thing that.
Yeah.
So I think it's very important that the COVID thing, it is common to diabetes also. The virus enters through the ACE2 receptor, that enters the body, the lungs. So these receptors are there in the heart, plus the beta cells as well. So you get post-COVID diabetes also, the sugar levels also go up, and during COVID, the sugar levels go up. And one mechanism also is postulated that the virus itself can enter the myocardium through this ACE muscle and cause the inflammation. That's the one mechanism.
Thank you very much for adding and very important aspects of COVID-related complications. Next, we have another question. I think this is again for Madam Naomali Amarasena. Can you please explain few medications for heart disease? Madam, can we explain the essential medications that we usually prescribe for patients with heart disease to prevent further heart attacks?
Yes. Well, if it is only to prevent further heart attacks, it is more a question of looking at this risk factor management. That is when it comes to antihypertensive medication and cholesterol medication. I can probably talk a little bit about the cholesterol medication. Everybody knows about the statins. There are other drugs as well, but these are the most investigated and the ones where the most amount of trials have been done and which are almost universally used in all patients with heart disease. So that is like you get rosuvastatin, atorvastatin, so on. They are what you call HMG-CoA reductase inhibitors. But there are other drugs as well which are coming to the market now, not here as yet, which are injections which are acting at different points of the cholesterol manufacturing mechanism. That is just for cholesterol. Then antihypertensives, you have various groups. You have the beta blockers, you have the calcium blockers, you have various other types of antihypertensives which are used to manage high blood pressure. But I think the question is not so much how to prevent. It is more what a heart patient needs.
Yes,
in other words,
prevention.
What you need is really secondary prevention. And that
yes.
is, we are talking about the importance of aspirin. I think I mentioned it earlier that somebody should actually give a person an aspirin if you are suspecting a heart disease. You see, the antiplatelets are very, very important. And if you are any chance you're getting a typical chest discomfort, which you yourself think that might be a heart attack, what you really have to do is to take about 300 milligrams of aspirin and chew it. Because basically what happens is, as I mentioned earlier, when it came to the pathogenesis also of the development of the plaque or the plaque rupture, first thing that comes to any kind of injury, and in this case also it's an injury within the artery, are platelets. The platelets are the first lines of defense in any kind of injury. In this case, it actually causes harm because you get a lump of platelets coming in, which later on it becomes, you get thrombin. First you get the white clot, which is the platelets, then you get the red clot, and then finally you get the fibrosis and the fibrin coming in. Now, what aspirin and the other antiplatelets like clopidogrel and so on do is they break up the white clot or the platelet clot. So you can really hit the heart attack at the time you're getting it. So that's why it's so important that you should have that aspirin with you, particularly on your bedside table, because early morning when all your stress hormones are at their highest is about the time that many people tend to get their heart attacks, and you really can't be running around looking for aspirin. So just keep it with you. Always carry a couple of aspirins in your purse or wallet or whatever, because that's such an important tablet, and it's probably the cheapest way and most effective way of sorting out a heart attack. So apart from the aspirin, now you get somebody with heart attacks, you will be on your aspirin, you'll be on your statin. Then you'll also be on drugs which are given to reduce your any kind of chest discomfort you're having. So in other words, now for instance, somebody with angina who has got chest discomfort relieved by rest, and you want to, first of all, before you do any of your investigations, you like to give drugs to relieve the person's discomfort. So you give drugs which tend to expand the arteries, which are called vasodilators. So you get nitrates and a whole gamut of other drugs, which I don't want to go into, which all help to improve your blood flow. You also give them a little spray or a tablet to keep under the tongue, because the moment you get this discomfort, it is your heart asking for help when you're not having enough blood going in. So it is important that you should actually provide that blood. And you can do that by dilating the artery. So you take this nitrate, which is a vasodilator, which is in the form of a spray, and you squirt it under your tongue, and you find that there's almost immediate relief. So these are the heart drugs which you really need. The essential ones, as I mentioned, are the aspirin and the statins. The other ones are all really risk factor modifying drugs, or which are given for treatment. For instance, you would be on a vast number of medications for diabetes. Then if you have high thyroid disease, you'll be on something for that. Your antihypertensives. So actually, it's not just the aspirin and the statin. You end up with a whole gamut of drugs, because the moment you get your heart attack or angina, or you're diagnosed as a person with ischemic heart disease, you maintain a different set of values. For instance, that number I was talking about, a number of less than 200, it drops to much less than that. You are aiming at an LDL of 50, not 100. You're aiming at what you're trying to do is, because there's something called regression of atherosclerosis. So what you're trying to do is, by bringing down the LDL to those levels, you're actually making the plaque regress. And that actually has been angiographically proven. So you try to do all that once the patient has been diagnosed with heart disease. So this is part of secondary prevention and also part of treatment, because the statin is not just a preventive drug, it's given for treatment as well. Okay.
Thank you, Madam. I would like to ask a question from Dr. Manilka, because Madam mentioned about aspirin. So patients with diabetes without heart disease tend to take aspirin as prophylaxis. Is there a benefit of taking aspirin to prevent heart disease in the future? Patients who are not having heart disease.
Okay, so it's a controversial topic, primary prevention of heart disease. Aspirin, as a, earlier we used to use it liberally. Any person above 50 years with diabetes basically got aspirin. But there was a subsequent meta-analysis which showed that just giving across the board, to everybody, aspirin won't be helpful, because there were in other countries the side effects of aspirin as well. The gastrointestinal bleeding, and some had massive bleeds, and there could be increased death as well. So the American Diabetes Association, and of course they agree with the European and the heart associations worldwide, have recommended that if you have diabetes and another cardiovascular risk factor, having diabetes per se, you may have realized it's a risk factor itself for cardiovascular disease. It causes endothelial dysfunction. It's a cardiovascular sort of a risk factor, a major risk factor. So if you have another one like hypertension, and if you're above 50 years of age, and you have a high cholesterol level, the values which were given before, and even urine microalbumin positive. So that reflects the status of your small blood vessels in the heart also, because it comes out in the urine, it can be detected. So if your kidneys are leaking proteins, then there is a case of adding aspirin for those people as a primary preventive method.
Thank you, Dr. Manilka. There is another question to you with reference to Dr. Manilka's explanation regarding ACE receptors. Are ACE receptors distributed equally in all tissues?
No. So this came to the limelight of our understanding, and a lot of studies going on after the COVID. These are well-known receptors, but they are more. I think the density is more in the lung tissue Then you get it in the pancreas, you get it in the heart, you get it in the kidneys. Yes, it's a sort of, it's there in most of the tissues, but I'm not quite certain. Even in the brain, it's there, but I'm not quite certain it's all tissues, but the densities differ in this thing. But the most important factor in diabetes, which I have studied on this aspect, is that in diabetes, these ACE receptors are upregulated for whatever the reason. So if you are infected with the virus, they tend to take it in more to your lungs. Could be your heart or any other tissue. It goes in faster. So that's why worldwide the diabetics have fared badly with COVID infection.
Thank you very much.
Tell you just another word about ACE. You see, the ACE inhibitors are drugs which we give for both heart failure as well as for high blood pressure. And moment where this ACE came into this picture, people started actually stopping giving these drugs, which was actually a big mistake.
Yes.
Because giving the ACE inhibitors was not really causing a problem.
No, they were actually helpful.
They were actually helpful, that's the thing.
But so all heart associations, diabetes associations came out and said, continue the ACE inhibitors. There is no connection with the ACE receptor there.
Thank you very much for the explanation, Dr. Manilka and Dr. Naomali. Madam, we have another question. What is the safest level of LDL for a person without diabetes? Madam or Dr. Manilka, you can answer the question. What is the safest level of LDL for a person without diabetes?
I think Madam can answer.
Yeah. I think there's nothing called a safe level of LDL because you see there are so many risk factors involved. You know, if you've got multiple other risk factors, yes, you see they combine. But the thing is, supposing you're let's take a hypothetical case. You're a 30-year-old, no family history, you know, no high blood pressure or anything like that, but you got a very high cholesterol. Now first of all, of course, we would ask them to go and do some lifestyle modification. But even without the lifestyle modification, if your LDL is over 190, you're expected to start treatment because you're coming into the familial category. So it's not the safest. I will rephrase it as the most dangerous level. Anything less than that, in a person who has no other risk factors, and when you do your risk stratification and all that, you find that they come into the very low risk category, you go for lifestyle modification. But anything over 190, you actually have to treat with the medication.
Thank you very much, madam. And another question to you, how chronic stress can trigger MI? How chronic stress can trigger MI, myocardial infarction?
Actually, I think Manilka can answer that because it seems to be more hormonal. Of course, the blood pressure going up also can cause it.
Yes, I have read about it. There is no proven theories or anything. It's a very stress cannot be quantified. That's what. So we know that stress will increase your heart disease risk. The stress will increase your blood sugar levels. So with stress, there are many hormones that come out. Your adrenaline, your cortisols, and your growth hormone. So if you look at the functions of those hormones, the adrenaline would be the fight or flight hormone. Your heart rate increases, the pressure goes up, right? And so that is generally our genes are hunter-gatherer. Like the photograph I showed you, our genes are still hunter-gatherer sort of genes that are suitable for living. So if you have your adrenaline surge, you are in front of an animal or a situation, either you run or fight. So now in modern world, people have stress in front of their screen, seated whole day. So when your adrenaline levels go up and your cortisol levels go up, these hormones will increase the output of your sugar from the liver, and they will increase your blood pressure as well. Both will be detrimental to your blood vessels, and that can cause an increased risk of plaque rupture and a myocardial infarction. So these are all stress-related hormones. So yes, it can cause increased risk for all the strokes or myocardial infarctions and plaque ruptures, so on and so forth.
Actually, it's not just chronic stress, it's acute stress also is causing this problem. For instance, all these, the people who are dropping dead while standing in queues,
Yes.
that is a question of acute stress. I mean, I had one patient who had, with zero risk factors, absolutely fighting fit person, who developed this myocardial infarction. Fortunately, a good Samaritan took him to a nearby MediHealth where they actually gave him the aspirin, and actually, I think they basically saved his life. But when we did the angiogram, he really didn't have plaques. He just had a plaque rupture and a clot. So that obviously was a stress-induced plaque rupture because he had no other blocks anywhere else. So that was just one of those skew deaths which was prevented thanks to some people intervening. But I think we have to take acute stress also as being a rather important cause of getting a myocardial infarction.
We have a few more questions. Another question to Madam. What is the use of oils such as polyunsaturated oils to reduce cholesterol levels? As you talk about these polyunsaturated...
Well, I think I mentioned that both polyunsaturates and the monounsaturates, they're all things which actually reduce the LDL and increase the HDL. They are basically called the good fats. So they make the right changes in your fat composition, which is the opposite of the saturated ones, and particularly the trans fats, the hydrogenated stuff, which is probably the worst stuff you can take.
And there's another question about blood pressure. I think Dr. Manilka, you can answer. Can blood pressure change with the age?
Well, of course, it's Madam's question again, but let me comment. Yes, it can with the hardening of the arteries. If your atherosclerosis is with age also, long-standing hypertension, your arteries can get hardened. Diabetics, you can see that, but we can't condone a higher pressure because of the age. Those days, I think some people thought your age plus 100 should be your systolic. That is not the case.
There was a formula.
Formula. Yeah. Age plus 100, I think even as medical students for some time, we would have this thing. But now you have to have a safe level, whatever the reason, even if your arteries are hardened, there are drugs to reduce or medication to reduce the blood pressure. So you should get it down to a safe level of about 130/80 or 130/85. Madam, you would like to add something?
No, I think I just agree with that. I mean, now we don't take the age into consideration when it comes to managing hypertension, but naturally the blood pressure does go up with age. I mean, the risks of any disease go up with age, whether it's heart disease or anything like that. That's why you're finding that all these diseases are there in the older population, except for people who have got various other causes which can give rise to your developing high blood pressure. So it's not just so much that it goes up with age, it's just the fact that age should not be taken as a sort of excuse to condone a blood pressure of say 160/90. You see, you still got to bring it down to the expected levels, because otherwise those same problems will occur. You will have a high incidence of heart attacks, high incidence of strokes, and so on and so forth. There's a hand up, Doctor.
And we have another question. Any real relativeness of COVID vaccine and post-vaccination MI? I think we talk about, I think she's asking.
People are far too scared about this vaccine. You see, what people are forgetting about is that what the vaccine is doing is it's reducing the incidence of COVID, and it's also reducing the severity of COVID. Now, we have seen far too many post-COVID patients who are coming with heart attacks and probably strokes and everything else. It's just that I see the heart attacks. And also the myocarditis is also quite a problem. I mean, we're seeing 18, 19-year-old girls coming post-COVID with heart rates of about 150, 160, which is absolutely terrifying then.
That's the thing.
So the disease is worse than the prevention. You see, the disease is worse than the vaccine.
I think we mentioned about it.
Yeah, I know. It's like 1,000 times more. They don't realize if you get COVID, getting a silent myocardial infarction without any symptoms in diabetics is much higher than from the vaccine, 1,000 times more.
Right. I think we have answered almost all the questions sent.
There's a hands up.
Hands up.
There's a hand up. Someone wants to, I don't think, Dr. Arundhati, she sent a question whether she needs to ask another question if she's with us. So you can talk or you can send your questions to us. Dr. Arundhati?
Yeah.
Maybe by mistake.
I think that's
Probably. She has
probably
sent a question. She has sent the last question to us. So as we have answered all the questions, I think it's time to wind up today's session. I think we had a good, it was very active session, a lot of questions. You want to add anything, Dr. Manilka?
No, I was just thinking maybe she was saying just bye, to get time.
Must be.
It's time that we leave.
Nearly 2 hours gone, I think.
Yeah.
So we had a good session today. Our two topics were ischemic heart disease, that is a heart disease, myocardial infarction, and how to identify a heart disease and the risk factors and prevention, the most important thing, the prevention, and also the treatment. And then we had another lecture on a very important aspect, that is diabetes. So we talk about diabetes, diagnosis and management and prevention. So we have come to an end of a very useful webinar now. This was conducted by the Ceylon College of Physicians in collaboration with Sri Lanka Veterinary Association. As Professor Arosha Disanayake mentioned, in keeping with Ceylon College of Physicians theme for year 2022, Bridging Gaps and Crossing Divides, this became a successful effort to make ties with other professional bodies. So before concluding the session, I would like to thank Dr. Susantha Mallavarachi, President, Sri Lanka Veterinary Association, and Dr. Chamari Kannangara, Secretary, Sri Lanka Veterinary Association, for inviting us for today's webinar and coordinating it very effectively. And I would like to extend my sincere gratitude to Professor Arosha Disanayake, President, Ceylon College of Physicians, for the guidance and support. Next, I would like to thank our speakers for today, Dr. Naomali Amarasena, Senior Consultant Cardiologist, Sri Jayewardenepura General Hospital, and Dr. Manilka Sumanatilleke, Consultant Endocrinologist, National Hospital of Sri Lanka, for their excellent presentations. Finally, I thank all the participants for their active participation. Over to you, Dr. Chamari Kannangara, Secretary, Sri Lanka Veterinary Association.
Thank you very much, Dr. Lushanthi. And finally, I must thank all of you. So today, it's a very useful webinar we had. And this webinar is different from the webinars which we had previously, because normally, as I said earlier, normally we have our webinars are mainly focused on the animal health, but today it's human health. I'm sure our members have gained very good knowledge about diabetes and heart diseases. So I must thank Professor Arosha Disanayake, President, Ceylon College of Physicians, for giving this opportunity for us to have a collaborative webinar with the Ceylon College of Physicians. And thank you, sir, for being here with us and coordinating this webinar. And next, I would like to thank today's two resource persons, Dr. Naomali Amarasena, Dr. Dr. Manilka Sumanatilleke. Despite of their very busy schedule, even on a Sunday afternoon, thank you very much for spending your time with us to educate our members, the Veterinary Association members. Thank you very much for being here. And next, I would like to thank next I would like to thank our President, Dr. Susantha Mallavarachi, and the Executive Committee of Sri Lanka Veterinary Association for arranging this webinar. A special thanks goes to Dr. Sugat, Ex-Secretary. And also, finally, I like to thank all the participants who participated today's event. Because of a Sunday and May Day, the number of participation is less. But since this webinar telecast live on YouTube, they can watch the webinar later. I'm sure our members will get the benefit of watching it in a later time. Finally, and also not least, my sister, who is the moderator today's program, the consultant physician, Dr. Lushanthi Kannangara. Thank you, Dr. Lushanthi, for arranging this webinar and discussing with us and arranging this very informative webinar for our members. Thank you very much. And finally, I would like to invite our members for our next webinar that is scheduled on 8th May, next Sunday at 1 o'clock. The topic is behavioral disorders in pet animals, and this webinar will be conducted by Dr. Eranga Rajapaksha. So thank you very much, and have a good next week, and have a good night. Thank you, Doctor.
Thank you, everyone.
Dr. Sugat?
Yeah.
Dr. Sugat, can you stop the live streaming?